So hello and welcome to the Hooked on Health podcast. I am joined today by Dr. Boisvert of Worcester County Orthopedics, their newest orthopedic surgeon, and just delighted to have you. So
yeah, thanks very much for having me. I'm happy to be here. And I joined Worcester County Orthopedics just about 2 years ago. I knew Dr. Vinton from almost 25 years ago now, and we trained together at UMass. So it was nice to come back and join him and Dr. Leahy, who I knew as when he was a medical student. So a long history of both those surgeons, and happy to be with the practice.
That's excellent. So tell us, a little bit about yourself. So you grew up in Shrewsbury, trained through UMass. What's it been like kind of returning to the community that you grew up in?
It's actually been great. I mean, I grew up in Shrewsbury. I went to med school at UMass, and then I did stay for residency, which was a wonderful experience. When you get a lot of experience doing lots of trauma surgeries and joint replacement and really everything, and a lot of hands-on training at UMass, which was part of why I stayed. And I feel like that still continues to serve me well now. I did leave for 1 year to go down to Philadelphia for fellowship, and then have been working back in Massachusetts since then, but kind of circling around Worcester. So it was really nice to be able to come truly back home and really be back in where I grew up, and where there's still so many people that I know and my family knows, and it's kind of fun to see your patients in the grocery store and be able to say hi and see how they're doing, and it's been really nice. I've gone back to my high school and talked on panels about women in medicine, which is great. I went to Notre Dame Academy, which is still an all-girls school, so it was really kind of fun and exciting to be able to go and hopefully inspire some people not only to go into medicine, but maybe orthopedics. And we're still less than 10% of orthopedic surgeons are women, so still hoping to boost that up a little bit. So that's been really nice too, is to be able to have that sort of connection to where I came from. And my biology teacher, who was retired, came just so she could say hi, and that was really fun. And it's been really, really nice. Actually, probably even better than I would have anticipated, from that sense of being able to have that connection to so many people. And then just from a work-life balance, right? Having 4 kids, things get really hectic and chaotic really fast, and this lets me be close to their schools and their activities, and be able to really kind of try to do it all.
So what's it like when you can't do it all? Because it's going to be, we've got 2 little girls,
yeah.
And we have a lot of help between family and
Yep.
helpers and things like this.
Right.
How do you manage it all? How do you act at as the highest level of professional one moment, and then
Yep.
the best mom in the other moment? How do you?
It is well, right. I mean, you have to ask for help, and we are very fortunate, right? So my parents thankfully live very close and are still very healthy and active, and so they help us out tremendously. Our community and our kids, friends, parents are always willing to help us out, thankfully. Little exchange of a sideline, hey, I have a question about my shoulder pain, and hey, can you pick my kid up and take him to practice? So it works out quite well. But we are definitely lucky, and definitely ascribed by, the having a village to help us. And that is definitely something that makes it possible, is that, we have those people around us who are willing to help us and happy to adopt our child for a day. I mean, we have 3 who are very active in sports, and even when there's just the 2 of us, we obviously can't go to all 3 if they're in different places. So I think part of it is our kids have just grown up knowing that this is what mom does, and my husband is also a surgeon, so they know when we're on call, things are fluid, and everybody has to be flexible and roll with it. And hopefully they are understanding that and helping them to kind of be able to have that flexibility and not be quite so rigid in things. But so they do. They sometimes think that we're gonna do something crazy, on the side. Mommy's hurt. You got to go help him. It's like, I don't have an X-ray machine. I can't right now.
Yeah.
I'll try, but so sometimes it's fun, and usually they just roll their eyes, and when I try to talk to them about work, or they walk by and I'm looking at some new product or video of a new technique or something like that, and they just like, oh, that's gross.
Yeah, I can see that.
I don't think any of them will be surgeons, but that's okay. You never know. You never know. So.
What drove you down the path to want to become an orthopedic surgeon?
So it actually was almost totally random. So I always knew I wanted to be a doctor as much as I could remember. I was either going to be a vet or a doctor. And then I spent a couple of weeks with a family friend who was a vet when I was in high school, and it was really depressing. I didn't know how much they like euthanized animals, and I said, yeah, I don't want to do that. So I went to medicine, and I went to medical school thinking I would be a pediatrician. And then I spent some time with who is our current pediatrician, who I love and have tremendous respect for, and I thought there is no way I can do this all day long. And I had loved anatomy, and I thought, okay, well, maybe I'll do something more sort of procedural based or hands-on, and ended up again sort of last minute switching a subspecialty rotation with a friend of mine who wanted nothing to do with surgery, let alone orthopedics. So I said I would do it. And so it was in my third year, and on our surgical rotation, I spent 2 weeks on orthopedics, and they let me do things, and I get to put in a femoral nail, and I said, this is amazing, and it was really fun, and that was that. So it was never planned. And I think I definitely benefited from being at UMass, and that, again, where there are so few women in orthopedics, UMass has always had a pretty strong contingent of female residents and female attendings. And so it wasn't, a question that they were going to let me do stuff as a med student, just like they would with anybody else. So I think that was really sort of fate and fortuitous that I got to have that time, and so just loved it. And that was, like I said, my parents were sort of like, do whatever you want, and it was a little, anxiety-provoking thinking about, well, what is that lifestyle going to look like, and am I going to be able to have kids, and how is that going to work? But you just do it. And
You just figured out
you just do, right? You're like, well, something will happen, and so I mean, it's definitely worked out for the best for me, thankfully. But it's there, right? You miss holidays and you miss some things, and but overall, it is worth it to me in the end that we're getting to help so many people. My kids see that we are helping people, but still making it to 95% of their things, and they are good at sharing us. So it's good.
Yeah. The balance is tough.
Yeah.
You're an athlete. You are an athlete.
Was.
I feel like that the definition of an athlete kind of changes and you go through life,
Yeah,
right?
okay. We'll do that. Yeah.
I think that let's talk about your athletic background a little bit, and then talk about how your experience in athletics has shaped how you treat patients.
So I did kind of some very different things in the sense of, I played field hockey. Again, sort of fell into that. Our high school at the time did not have a soccer team, and that's what we had played growing up. So there was no other option, so it was field hockey. And then was fortunate enough to be able to go on and play in college, which again had never been part of the grand plan, but worked out, again, gratefully for that. So, in high school, it obviously kept me very busy. So I played field hockey, and then I was pretty serious about ballet. And so, I would dance 5 to 6 days a week. We would go from field hockey straight to ballet. So my time management skills and my efficiency were pretty well honed by the time I graduated from high school. And then I rode horses growing up too. So had that responsibility. We, were fortunate enough to have a small little kind of backyard barn in the center of Shrewsbury. So, had a lot of responsibility and had to figure out how to make it all work. And so I think that has translated well into the chaos of my life now and doesn't faze me.
Yeah.
And then I, have always just enjoyed being active and doing those things. So you kind of picked up things as life changed, right? So I went to Wellesley College, that's the Scream Tunnel at Halfway Point in Boston Marathon. It's a huge party on campus. So I was like, why am I standing here on the sidelines? Like, I want to go and run this thing. So senior year, I told my dad, I said, I want to run the marathon. And he had run it in his 40th birthday year. And so he, I guess I kind of follow after him in a lot of these things. So he was like, okay, great. I'll meet you halfway and I'll run the last half with you. And I said, okay. So he gave me all his old training routes, and I would, it was back when you could still run it as a bandit. So my first time I ran it as a bandit.
Okay.
But they let you finish. They let you start and they let you finish back then. So that was great. And then I got the bug of running, and then I ran 3 more marathons after that. In the course of a few years, even as I started into residency. So during medical school, I ran 1, and then in residency, I still ran another 1. But that was harsh because I did not really train for it, but I thought I could do it and paid for it for weeks afterward.
Yeah,
so I definitely don't recommend that to my patients. Do not just decide to up and run a marathon. Right, when you're running 2 or 3 miles at a time. And then similarly, I kind of randomly saw a IMAX about Kilimanjaro, and I came home when I was in medical school, and I came home from a weekend out with my friends where we had seen this, and I said to my dad, I want to climb Kilimanjaro, and he said, okay, cool, let's do it. So that was my med school graduation. Right after that, my dad and I went and hiked Kilimanjaro. So I feel like I'm able to draw right on all those sort of very different fields in terms of, team sports, dance and ballet and the whole world that comes with that. And then, horseback riding and equestrian events and hiking, running distance, and, it's all fairly different things, and be able to have those conversations. So I feel like, and then once you kind of meet with a patient who's maybe in one of those fields, that word spreads. So, then I end up, you took care of my friend, from the barn, or my friend that I run with. And so you get a lot of word of mouth referrals from that. And I think it also, I was never going to do any of those things professionally, but it was incredibly important to me and my happiness and what I wanted to do. So, I feel like a lot of times people will be kind of dismissive, especially female athletes, of what are you going to do with this? Where are you going to go with this? And so I hope that I can bring that, especially to that group, but to everybody, obviously, that I understand, even though it's not your profession, how important it is to your quality of life and obviously your overall health, to be able to make sure we keep you doing it as long as we possibly can.
Yeah.
So I always tell people, a lot of times we'll see a lot of people who say, well, I saw somebody 5 years ago and they told me I could never run again. I'm like, well, never say never, but, maybe you cross-train more. We find some kind of compromise to be able to let you keep doing the thing you really want without necessarily totally destroying your joints in your body.
Yeah, and that's the balance of a team.
Right.
And I think that's where, PTs and orthos working together for the patient is huge.
For sure.
I personally, I don't use the word, my mom would always say, use the word dislike greatly. I hate when people tell people they can't do something for the rest of their life, you know? Because if I were that person, I would question the heck out of it, right? I'd be like, there's no way that somebody's going to tell me, no, I can't do it. That means that I'm going to figure out a way to do it.
You can do it, yeah.
But let's talk a little bit more about, I want to hear about your perfect patient, or the patients that you love to treat. So let's start there, and then we kind of talk about how, what different options patients have other than surgery when they come to see, because I feel like that's sort of a fallacy. Is people come in, Sean is sending me to, Phil or Brittany or Chris, I need surgery, and that's not the case always, right? So let's talk about that.
Yeah, so definitely not the case. I think probably sort of the perfect patient is the patient that comes with an open mind. I mean, a lot of times patients will come in, now it's ChatGPT, it used to be Dr. Google, now and now they've gone to ChatGPT, and they have in their mind what is the diagnosis and what they are going to have happen, and a lot of times they will start off with, I don't believe in physical therapy, or I did physical therapy 10 years ago for a completely different problem and it didn't work. So therefore now it's not going to work for this.
Or I did it and just got exercises.
Right, yeah. I'll just do it at home. Yep. A lot of those sort of conversations. And so I would say the majority of things that we see can be treated with physical therapy. Even the things that may often go on to surgery for at least, a significant period of time, people can get much more improvement with physical therapy. Things like meniscus tears, definitely arthritis, shoulder problems, rotator cuff injuries, shoulder instability. Like, there's a lot that can be treated with physical therapy. And I think, there's certainly a lot of that relationship between the physical therapist and the orthopedic surgeon to make sure that everybody's on the same page. Yeah. I treat a lot of fractures, and I never forget it. I had one patient who had a really bad ankle fracture, and he came back and said, well, my physical therapist told me that I'm never going to walk normally again after 2 visits. And I said, let's slow that roll. He said, you've had 2 visits. We said, this is going to be a long process. We need to have a positive outlook. And so I think that's definitely an important thing that they're getting from both sides, is that, yes, this will work. And actually, I just saw him recently for his final visit. It was a year after his surgery. And I said, so what do you think? Remember in the beginning? And he said, yeah, I'm back to running. I feel great. I'm walking totally normally, no issues. And I said, right, so I think that mindset is critical, and getting it from both their physical therapist and from the surgeon helps tremendously. Even if the physical therapy perhaps doesn't quite get them all the way to where they want to be, everybody is better off for having done the physical therapy before surgery, if it's feasible, depending on what the underlying problem is. So it definitely just makes their recovery that much easier if they've already been in therapy.
Yeah, it's funny you mentioned, the language that we use as providers with patients matters.
Right. And it may not have been that was the exact words that were, said, but that's what that patient took away from that, right? Yeah. Was, I'm never going to walk normally ever again. He's a young 30s, right?
Which is yeah, I mean, it's just, and PTs, if PTs are listening to this, like you just, in this lesson, I probably continuously learned throughout my career, but I've really learned over the last, 20 years, you have to be really careful of how you word things. And in school, they used to call it, patient-friendly language, and we literally had like quizzes on this. Like, it was as ridiculous as that sounds. You'd have, and then we'd all laugh about it, and but then you get out in the clinic and you see how your words really affect outcomes.
Oh yeah.
And people's adherence and diligence to exercises, right?
For sure.
Because that all matters. I think success, the triangle of success between us, like ortho, PT, and the patient, really, the patient has a role in that too.
Absolutely.
So it's our.
You got to put in the work. Right?
Yeah, they've got to put in the work, and it's our roles to make sure that their role is clear. But that's I love that. I had a thought that I was listening, and I will come back to it when it pops up in my brain. Yeah. But in your opinion, you talked about fractures. What are some things that come into your office that you're like, okay, the conservative care is out the window. They either need some sort of a real medical intervention.
Right. I mean, fractures are probably obviously the most obvious one, and even some of the fractures, though, sometimes we'll say, we can give it a few weeks and see what's going to happen. But those are probably the most straightforward of surgery or no surgery. The only thing that I typically would be more aggressive with in terms of saying, this isn't something that we can do physical therapy for would be known full thickness rotator cuff tears, especially in a younger patient. Even if they're small, a lot of the literature now says if you wait, it's just going to get bigger. And I always said patients, like, if we get to it while it's small, I can let you do your rehab a little bit faster, and hopefully your outcome will therefore just be that much better. It's not going to heal itself and reattach itself to the bone. So, but there is always that option to say it's small. Is what are you trying to get back to? Is it your dominant shoulder? Is it not? How much does it bother you? So there's certainly, even in that situation, could be a role to say, let's see how much better you could get for the folks who say, I'm really just not interested in surgery. So we can guide them through that process. The only other, and again, there are certain, things like avascular necrosis in the hip. There's not a whole lot you can do for that other than replace it. So there's few things where, first time around I say, we just got to do surgery. Folks with like bad deformities and significant stiffness with knee arthritis, really extreme things. I would say probably 90 to 95% of the stuff I see in the office, physical therapy is always an option.
And they may have already failed conservative care.
Right. Yeah. Right. And sometimes they will come to us and have been in 3 months of physical therapy and they've been on anti-inflammatories and, their primary or rheumatologist did an injection or something like that. And then, you say, okay, well, if you're not satisfied with where things are, here are the other options that we have with surgery.
And that's what I tell our PTs too, because we see a lot of direct access patients coming off the street or, word of mouth, friends and family directly to us. Mm-hmm. And, I'd say that's probably 50% of who comes in the door. So I'd say like 30, 40% is doctor referral, and then the other is like word of mouth and people directly from the street. Mm-hmm. And so, we'll treat conservatively, but I tell I tell our staff, like, here's a list of who we, we're constantly adding and subtracting sometimes who we use, who we refer to. Here are our referring partners. Make sure they have an appointment on the books after 3 months.
Yeah.
Right? Like, go see, Dr. Boisvert if, there isn't any improvement, or you're not meeting your milestone.
Meeting
so
goals.
Every month we should be doing reevaluations if not sooner, 8 to 10 visits. And if they're not 80% better within 12 weeks, or they are 80% better, but they want that last 20%, go see them.
What else can we do?
What's the downside? Go get a cortisone shot.
It's a conversation, right? You're not signing up for surgery on.
You're not, but some people think, some people think, Sean wants to send me to an orthopedic surgeon. He thinks that I need surgery. I'm just going to cancel the appointment. Well, in reality, it could be PRP.
Right.
Could be cortisone injection. Could be another conversation that, we just don't know about.
Right.
Talk to me about research within the last 5 or 10 years that's changed maybe the way you've treated a certain condition. Putting you on the spot.
I was going to say, the rotator cuff is probably one of the bigger ones because, 10 years ago, we would have said a really small, full thickness tear, therapy, cortisone injection, don't worry about it. I feel like we are much more aggressive now.
Talk about what a full thickness tear is, just for our audience.
Yeah. So the rotator cuff tendons attach to essentially a fairly broad footprint of bone in the shoulder. And so most of the time, what we see are partial thickness tears, meaning some of the fibers have detached, but there's a certain degree that's still attached. And those 100%, physical therapy, conservative care. There are times, though, where a certain portion of the 4 tendons of the rotator cuff will be completely detached. So 100% of the footprint is off. Okay. A lot of times, again, in the era of electronic medical records and everything else, people will come in and they say, but it says tear on the MRI report. And you say, and so that's where being able to show them the images is always super helpful, right? So you say, yes, there's a partial tear, and here's this centimeter wide footprint, but you have 2 millimeters detached, but 8 millimeters still attached. Yeah. And therefore I can't make that necessarily better with surgery. Or there will be a full thickness tear, but it's a tiny pinpoint and it's, 2% of the rotator cuff. Those, again, that's not what I'm saying, sort of small full thickness tears. The small full thickness tear would be where it's at least, a fairly significant portion of one of those 4 tendons, if not multiple tendons.
Yeah.
And it's completely detached, 100%.
And we're talking about tendon bone junction or muscle tendon?
And tendon bone junction, yes.
What do you see most commonly when you see rotator cuff tears? Because I think of intramuscular, musculotendinous junction, and then tendon bone.
The vast majority are tendon bone. There may be a little, sometimes there's a little stump of tendon left, so it's more intratendinous, where the tendon just kind of broke down over time, and then, it truly does just kind of peel away sometimes. Yeah. The musculotendinous ones are not easily treatable surgically, and thankfully, therefore, not
PT.
that common. Yeah, and PT. Shoulder treatment in general has really evolved with lots of different modalities and things when a tear is not repairable. So that's a very difficult conversation to have with some patients of, they were functioning just fine, and then they, something seemingly innocuous of, they bumped their shoulder or they kind of fell on it or, with a relatively minor thing, and now they can't move their arm. You send them for an MRI and you say, you've had a massively torn rotator cuff for years, and your deltoid has just been compensating. That's a very, hard thing for people to really kind of digest, because now you're saying, I can't fix that, right? Because the muscle has wasted away and the tendon's retracted and scarred, and going in and trying to fix that is not going to help them. Physical therapy often can, kind of reactivate the deltoid to get them back to where they were. And that is definitely a time where you say, yes, you have this, terribly torn tendon, but I'm going to send you to physical therapy.
Yeah.
And a lot of people will get better. If they don't, the options for that situation, that's probably one of the things that has really sort of blossomed in the last 10 years, definitely the last 5 years. And depending, again, on patient age, activity level, what they're trying to get back to, the reverse shoulder arthroplasty is something that has become much more common and is incredibly reliable and far more durable. So it used to be we would never do a shoulder replacement in anybody under 70 or 75. Now we're doing them in people in their 50s and 60s, and they're going back to the gym and they're lifting weights and they're playing pickleball and golf and everything else to be able to keep doing everything. So, and then and obviously that's again sort of the other extreme. There's things like balloon implants and all kinds of different things to help with that difficult scenario of those big rotator cuff tears. That just, and it continues to expand. So that's probably one of the bigger areas of development in the last few years for that pretty difficult problem. But
yeah, and I know we used to talk about the rehab for total shoulders, and whether it was total or reverse. Mm-hmm. And it used to be, and tell me if this has changed or not, that essentially the range of motion that they had going into surgery was the range of motion that they were to be expected to have outside of surgery. Has that changed?
I would say that's changed.
Okay.
Yes, and again, that depends on where they are, where they're coming in. So there are some patients who will come in and they have decent range of motion. They can get their hands to the back of their head and hygiene purposes and things like that, but it hurts. So we say, okay, well, I can keep you with that range of motion. You might lose a couple of degrees of that motion if you can lift your hand all the way up straight over your head, but it won't hurt to get there.
Yeah. And
then there's the other people who come in who can't lift their arm to shoulder height, and you say, yes, I can make that better. Again, it won't be like it was 30 years ago, but it will be better than it is now, and it won't hurt. And then on other times, it's a trade-off. So some people can still lift their arm, but it doesn't rotate at all. And a lot of it's sort of an underestimated movement of external rotation to be able to do normal everyday activities and not have to do these very awkward things with the shoulder to get it to work.
Yeah.
And so I just had that conversation of, you can lift your arm all the way up over your head. You won't be able to do that after surgery, most likely, but you will rotate. And so your motion in your shoulder overall will be much more normal and you will be more functional. So it's a very individualized thing, I guess. But I would say most of the people, their motion is going to be better for shoulders.
do you do the reverse?
I do the reverse,
Okay,
yes.
great.
So, and there's definitely been more of a trend. A lot of that is kind of based on talking with people who've been doing it forever and are the folks who are designing the implants and all these things. And the design of the reverse has changed a lot in the last 5 years or so. And so it used to be that the arm would be really kind of significantly lengthened. It wasn't really that great. You couldn't lift weights. You couldn't expect to do those kinds of things.
Yeah.
And it's really switched from being that sort of lengthening to really increasing the function of the deltoid and the fulcrum of the deltoid. So people can do a lot more with it. And the nice thing is, when you talk about it compared to a massive rotator cuff repair surgery and you're in a sling for 6 weeks and you're not, we don't let you move.
Yeah.
And then you're in therapy for months on end. And, with the shoulder arthroplasty, especially with the reverse, you wear a sling for a couple of weeks and then you start your therapy and you're moving pretty quickly. So from that sort of return to life and maintaining independence and things, that can be a huge benefit for a lot of patients. So.
Yeah, I think that's, and it's just, again, it's sort of that relationship between the patient, the PT, and you is like,
Right.
okay, Because if you've been lifting your arm 30 degrees away from your body for 5 years,
Right.
your muscles are now short.
They don't know what to do.
They're probably filled with fat, right?
Right.
Marbled, and there's no way you're going to have strength up in your new range of motion.
Right.
So I think, I think back to 10 years ago when it was like you keep the range of motion that you had going in.
Right.
Anecdotally, it never made sense to me because once you improve range, you should be able to improve the muscle strength throughout that range.
Yeah.
Now the rotator cuff, all of the footprint of the rotator cuff is gone, right? It's just the deltoid that's.
So you can, again, that's probably another thing that has changed fairly significantly is a lot of people, including myself, will do a reverse in people who have an intact rotator cuff, and it just makes it work even better.
Okay.
So it doesn't preclude them from having a reverse if they have an intact rotator cuff. It's been shown to be more stable and more durable. So those folks, who want to go back to golfing and bowling and other overhead sports like tennis and things like that, probably an anatomic shoulder would be still better for that than a reverse, just with the thought of being able to get your arm up that high. But there's no sort of set structure anymore that it has to be only in the folks who have big rotator cuff tears.
Wow, that's
so
great.
Yeah, that's probably another big swing in the last couple of years to say.
Indications, just pain.
Pain, function,
Yeah.
right? Failed everything else, right?
Yeah.
Again, it's getting to shoulder any joint replacement obviously is a big decision, and so it's not something you jump into, except for again fracture situations. Really bad proximal humerus fractures, reverse arthroplasty is a great option for those folks.
Yeah.
So it still is something, right? You would take everybody through the process. If you're meeting them for the first time and they haven't been to physical therapy and they haven't tried, if cortisone injections are an option, medications. We always talk about activity modifications. So, maybe you don't serve overhand anymore. You play doubles instead of singles. What are
Pickleball instead of tennis.
Pickleball instead of tennis,
Yeah.
right? So diehard tennis players do not like that conversation, though.
I know.
Nobody likes it, right? They're like, no. So I think it's a big conversation, but I think it can give the right person a really great outcome and maintain their function.
Yeah, that's tremendous. Let's talk about same-day surgery. Mm-hmm. So knees and hips. It's
Yep.
been that way for a little while now, but
Yep.
talk about what sometimes the mismatch between patient expectation and what actually happens.
Mm-hmm. So a lot of that has developed primarily from the anesthesia and sort of pain modality side, that now we are coming at it from lots of different angles rather than just narcotic pain medication. Certainly COVID had a big part of that too, because we couldn't keep people in the hospital and people definitely didn't want to stay in the hospital. But they still wanted their joint replacement. But for me, I had started it years before that, primarily because we could get people comfortable with nerve blocks and spinal anesthesia, and they didn't feel as groggy. They weren't having issues post-operatively with low blood pressure, dizziness, things like that. So using the different nerve blocks, we do not just the nerve blocks with the anesthesia service, but we use what we describe as sort of a cocktail of different medications directly into the joint at the time of the surgery, which means that anesthesia can give less medication so they wake up better, and they have less pain when they wake up. So that allowed us to then be much more aggressive with their physical therapy and say, okay, we changed the block from a femoral nerve block to an adductor canal. The femoral nerve block, nobody could lift their leg.
Yep.
So everybody was in a brace. They couldn't really support themselves, and they were really limited. So by changing that, I said, nope, you can get up. You can put weight on your leg. You can bend it right away. Nobody's in braces anymore. We could be much more aggressive and show them that, yes, you can move your knee right away or your hip. And then the other thing that helped a lot was the development and sort of much more widespread use of a medication called TXI, or tranexamic acid, that limits bleeding during the surgery. So it used to be, probably 20% of people would need blood transfusions after joint replacement. When I was a resident, we had some attendings who would have patients donate blood, a couple of months ahead of time in preparation for that.
Wow.
I don't think I've had any of my patients in the last 5 years need a blood transfusion. So that's another thing that obviously they just feel better after surgery. We used to have to put drains in everybody for their surgical sites. That kept them in the hospital. We never do that anymore. So there's been a lot of advancements in the other things surrounding the surgery. I mean, the surgery itself is still the same. Yeah. We don't do anything differently there. Yeah. It's the pre-medicating, with Tylenol and Celebrex in the preoperative area, the anesthesia side of things, and then the postoperative care. And I think a lot of people just recognize too, you're just more comfortable in your own surroundings at home. We have the benefit of home care services. So, PT and OT are coming out to their houses, a day or two afterwards. They're working with PTs in the hospital to make sure they feel, safe and up and around before they go home. But I think for the vast majority of people, they love it. And we're at a point now where even the folks who do spend the night in the hospital with us, if it's for medical reason, for observation, or if they just didn't feel great going home, I would say probably 90% of people go home the next day. Yeah. So it used to be, right, when I was a resident 20 years ago, everybody was in the hospital for 3 days, and then everybody went to rehab. There would be 1 or 2 a year who would go home after their 3-day stay in the hospital. Almost nobody goes to rehab anymore. And I think it's just been overall tremendously beneficial for patients because they are up and moving. They get their motion faster. And I think just being, like I said, being in their own environment, their own comfort level, and being able to, just take their medication when they want it and not have to ask the nurse and wait for it. And then it's, now it's too far gone and then they're chasing it all the time. So I think it's made a huge improvement in recovery and satisfaction.
Yeah, that's great. Do you guys still send home CPM machines or no?
Not for totals. Yeah. I still use it for ACLs, especially for if I do meniscal repairs, things like that. And that is really, that surgery hurts. I tell patients, I'm not going to lie to you, it hurts a lot. But I think just that little slow motion and then, for the meniscal repair, moving things around in the joint can be helpful for a healing process and things like that, but just not feeling stuck. Yeah. Because that's, in a lot of ways, that's a more difficult surgery than joint replacement. Amen. So it's a little bit of a different process, but I don't think anybody gets CPM machines for.
Yeah, I haven't seen that in probably 5 or 6 years.
At least.
When I first graduated, 15 or whatever, it was pretty common.
Oh yeah, again, same thing.
Continuous passive motion.
Everybody,
so it's just, they're machines that passively, bend your knee for you when you get out of surgery. That you have at home. They're clunky.
We used them in the hospital. People get sent home with them. We said you have to sit in this thing for 6 hours a day, and then you're not moving because you're in your CPM machine for 6 hours a day. And so there's a lot of things that have changed in that sort of recovery process. And hip replacements, right, we used to say, you can't bend over, you can't cross your legs, you have to sleep with this wedge pillow between, don't move. People were terrified and they weren't sleeping, and now the newer implants, things are more stable. I don't think anybody really uses those kinds of restrictions anymore.
And the approaches too. The approaches are, like Chris's approach is different than like a straight posterior.
I do posterior.
Oh. All right. You heard it here first.
But I have that conversation. I see a lot of patients in the office for a hip replacement, and they know that Chris does the anterior approach. And at this point, I think the literature has kind of borne out there's not a huge difference between the two because we get people just up and moving, and we don't have them on those restrictions anymore. And again, in the implants, things are so much more stable. The risk of either one can dislocate. The risk of that is still about 1% for either anterior or posterior. And
it's nice as a PT because you're in school, you have to memorize those.
Right.
And it's like if you
patients obviously hated it. And I even up until a couple of years ago, there was one surgeon that wouldn't let their patients walk up and down the stairs after hip replacement.
Ever?
We all get for like 3 months or something like that. And we all get kind of stuck in our ways and what you learned as a resident. You carry on. Sometimes it's hard to adjust, but it definitely has only been for the better. Patients come in for their post-op appointment after hip replacements, and most of them aren't using anything. No walker, no cane, no crutches. They're just walking. Yeah. I always use the example of I had one patient who came in for his 6-week post-op appointment. He was a tennis pro. And I said, how are you feeling? You feel like you're ready to get back on the court a little bit? And he said, I played in a tournament last week.
At 6 weeks?
5 weeks. And I was like, I don't know if I would have said okay to that. But great.
Good job. You could have done the 1%.
Right.
Do you ever do any double, like bilateral total hip replacements?
No.
I saw that once.
Yeah.
Like I was a maniac.
Yeah, right. And for a while, a lot of people were doing bilateral knees too, right? But I think most people have gotten away from that. We go through these phases, right? And then you realize, well, maybe those people aren't doing quite as well. We can stage them by 6 weeks, and they can really get a good start on that one side. And blood clots and just pain management, and it's a lot for sure. Yeah,
I can't even imagine.
Yeah.
Someone listening today is, dealing with joint pain, trying to decide what to do next. What's the first step that they should take?
I guess it's always good to start with the primary care doctor. That's usually where most people will start off, just to kind of get an idea of what might be happening, get some plain films and see what's there. We always, in orthopedics, kind of interpret the x-rays ourselves. So we sometimes have a different interpretation of things, or we will take different sets of x-rays and things to get different information. I think, from there, starting with physical therapy is typically the best place for people to start. And certainly a lot of people may just bypass their primary care, and come straight to you guys and I think it's thankfully becoming that much more of an option for people to be able to just come in and say, here's my symptoms, and you guys take care of them. And
and I think we try to tell people and that's where the relationship matters, right? So it's a doctorate field now. Generally, it's been a doctoring profession for 15 years, PT, and I would like to see PT become really that primary stop for musculoskeletal care for the basics, right? The internal medicine is so busy. Primary care is so busy. If you've got knee pain and it's something we can do something about today, right? Come see us.
Yeah.
Versus, if there are red flags, PTs are educated to triage that out.
Yeah.
Or if it's a fracture or something, that's a whole different conversation.
Yeah. And the field of primary care even that's changing a lot. There's more and more of the, not to use your name, but concierge sort of practices where they have a much closer relationship and better access versus, they might call their primary care and they'll get an appointment in 6 months if they're lucky, which is hard. They're just right. They're so overworked, or they're seeing somebody that's not actually their primary care, and it's a tough field for sure. So I think that's a little bit where our system is a little broken in terms of the insurances that still require referral for them to be able to come see you. They can't get to you until they get to their primary care, but they can't get to their primary care, and it's this kind of broken cycle. But certainly more helpful for them to be able to get into you guys faster.
Yeah, we try to make access as easy as possible. We always try to say, just like you guys, we'll get you in as soon as possible.
Yeah.
And oftentimes it's 48 hours, sometimes 24 hours.
Which is amazing. Yeah.
Because it matters that the timing matters. If you're in pain, we want to make sure that at least you have a plan.
Right.
Yeah. Closing tradition. Couple questions. Rapid fire.
Oh no.
Favorite book.
To Kill a Mockingbird.
Okay. All right. Favorite movie.
Princess Bride.
All right. And then a mantra. You can take a moment to think about this. But a mantra that you live your life by.
Nothing is too hard.
Love that. I love that. Well, thank you, Dr. Boisvert. Appreciate your time today. This is tremendous. And anything else you want to share with the audience before we kind of hang up the phone here?
No, I think
the podcast.
Yeah. I think, as you mentioned, Worcester County Orthopedics, right? We try to have a lot of availability for people. We do keep some urgent visits open so that we can get people in, because when you have an injury or something, you don't want to wait a month to be able to go see somebody about it. So just kind of want to spread that word that we are doing our best. And being a small private practice, when you call in, you're talking to one of our people who is 5 feet away from us and can run things by us. We can look at x-rays quickly and say, yes, we got to get you in right away. So I think that's one of our big sort of strengths compared to some of the bigger university systems and things like that, where you're getting some central scheduling and it takes forever to get in. So hopefully that's helpful for folks, and do our best to make sure we get everybody in.
Yeah. So we'll include all of the information to contact Worcester County Orthopedics in the show notes. And thanks again for joining me.
All right, thank you.
Awesome.